Hello and Vanakkam. Welcome to today's conversation on HIV and AIDS. My name is Scott Harnish, and I have been with the International Alliance for the Prevention of AIDS, IAPA, for the past 10 years. I have been on the board of directors, I have been the intern coordinator, and now I am a consultant and fundraiser. I am so pleased you have decided to join us today on our virtual discussion on this disease and how to prevent it. In this day of COVID-19, it was most important that we give you the most current information on how to stay safe and how to stay healthy. It is no longer a thought that this is only a disease in one country. We know now that every disease affects everybody in the world because the world is our backyard. And we are pleased to bring you information today, to bring you up to speed on all possible treatments and hopefully one day a cure. Today we will be joined by our CEO, Louis, and he has been with the IAPA office and team since the inception of the organization. Brittany Hale was an intern in 2016. She is currently an MPH candidate at the Mellman School of Public Health in Columbus University and a case investigator for NYC Health and Hospitals. Madeline Knowles was an intern in 2015. She currently works at the Learning and Training Management Center for Domestic Peace and Domestic Violence nonprofit serving the San Francisco North Bay area. And finally, Seema Gopi. Seema is our COM, our Chief Operations Manager of IAPA. She coordinates all field activities and all the accounts. I want you to listen today. If you have questions, please feel free to reach out to any one of us because only by information can we conquer this disease. I so appreciate you being here today and I thank you for your time.
Dear friends, warm greetings from Chennai. Every year during the World AIDS Day, IAPA used to conduct a lot of great programs in collaboration with educational institutions. But this year, due to COVID, we have to do everything virtually. Anyways, I am very happy to share with you through this video some points about the World AIDS Day. The theme of this year's World AIDS Day is Ending the Epidemic, Resilience and Impact. I think this has very great significance as on today as we are combating the COVID-19 pandemic. The COVID-19 pandemic has proved to be more of a killer disease than HIV because as on now, there are 37.9 million people living with HIV and 770,000 people have died of HIV-related illnesses. This has happened over a period of 40 years, 4 decades. But the COVID-19 has already infected 59 million people and 1 million people have already died. But there is a lot of hope as 3 candidates for vaccine have proved to be more than 90% efficacious. On this hopeful note, let me start to share with you some points about HIV/AIDS scenario in India. In 1986, in India, 100 sex workers were collected and their blood samples were taken for HIV testing and 6 of them were found to be HIV positive. So we say that officially HIV came to India in 1986. But actually when it came, no one knows. Then what happens? The government goes into denial mode. In the beginning, the epidemic was named as Gay-Related Immunodeficiency Syndrome, GRIS. So they said that there is no gay sex in India. In 1999, 1,400 Indians were being infected every day. In 2001, that increased to 4,000 Indians infected each day as the infection percolated to general population from the high-risk groups. 74% infection was through sex, 7% through injecting drug use and blood transfusions, and 19% through other means including vertical transmission. Southern and western states were beginning to be affected. Stories of fear, misconception, revenge filled the daily newspapers. On 26 April 1999, a village in Chennai, a man was lynched of being HIV. Story of Guru Gobind Singh in Sidsat village in UP in 2000 was a very sad story. He was thrown into a cowshed and died there without any mercy. Then the wildfire starts. From 1986, 4 years, most of the states in India, HIV spread. Then India became the third largest HIV epidemic center in the world. 2.4 million people were living with HIV. Prevalence in the age group of 15 to 49 years was as high as 88.7%. The epidemic slowly moved from urban to rural population. It was found that most HIV infections occurred through heterosexual transmission. 6 states were declared as high prevalence states: Andhra Pradesh, Karnataka, Tamil Nadu in the south, Manipur, Mizoram and Nagaland in the northeast of the country. Injecting drug users were having a prevalence rate of 8.71%. Men who have sex with men, 0.569%. Female sex workers, 5.38%. As you can see in the map, Andhra Pradesh has 1.5% and above, and all the other states are sharing 1 to 1.5, 0.5 to 1.10%. Tamil Nadu being below 0.5%. Then the country started to respond. In 1992, National AIDS Control Organization was established and National AIDS Control Program number 1 formed for the year 1992 to 97. The World Bank pumped in money, 84 million came to India, and due to the negligence, 40% remained unutilized. Hence, the National AIDS Control Program was extended up to 1999. Then there was a stress in the point that it is not a medical problem but a behavioral one. Blood safety precautions were taken. It was found that people suffering from sexually transmitted infections had 10 times more chances of acquiring HIV/AIDS. So, STI referral and treatment was started, condom promotion started, and social marketing of condom was launched. In 1997, only 67 voluntary counseling and testing centers were there. It was increased to 15,000 by 2014 and was made as integrated testing and counseling centers, integrating all the other treatment also. In 1997, USAID, DFID started targeted intervention projects. Prevention along the highway path projects, Women in Prostitution project, WIP, Slum Intervention project, SIP, Tourist Women in Prostitution project, TWIP. All these started. Behavioral Sentinel survey conducted for monitoring these projects, and the field level NGOs were called once in 6 months to share their experiences during the experience sharing and review meeting. Current scenario. As on 2017, India's HIV epidemic is surely slowing down because of all the efforts put in by various targeted intervention projects. Now there are 2.1 million people living with HIV. Between 2010 and 2017, New infections declined by 27%. AIDS related deaths more than halved, falling by 56%. In 2017, 79% of people living with HIV were aware of their status, of whom 71% were on antiretroviral treatment ART. Mother to child transmission reduced to 0.25%. However, the HIV prevalence among key population increased. This was a great worry for the HIV/AIDS planners. Talking about key populations, female sex workers, there are 868,000 in India, of whom 2.8% are living with HIV. MSM, there are 427,000, of whom 4.4% are living with HIV. Then again, transgenders are emerging as a group at high risk of HIV transmission with 8.8% prevalence. The transmission is happening through unprotected sex among these key populations and their clients, partners and spouses. That is why it is spreading more. There are 177,000 injecting drug users. Among them, 7% prevalence rate is there, especially in the Northeast. There are 7.2 million migrant workers in India, of whom 1% are living with HIV. An interesting fact is 75% of women testing positive in India have a husband who is a migrant laborer. There are 2 million truck drivers in India, of whom 2.6% are living with HIV. As of 2017, there is a slight decline in their HIV infection, but it is not much significant. Factors affecting progress to lessening HIV are stigma against key population. The Indian Supreme Court removed Article 377 that criminalized same sex. In spite of that, the stigma and discrimination goes on. Not only the stigma of being a key population, but HIV-related stigma, police harassment of sex workers and MSM, alcohol and substance abuse among them, illiteracy, low levels of status among people living with HIV. How to go forward is the question. Targeted interventions should cover 90% of the key affected groups and those at high risk of HIV transmission. Universal testing of the general population and more intensive testing of high risk groups on a 5-year cycle should be taken up. Then more people would know their HIV status and therefore actively seek treatment before developing AIDS-related illnesses. Links between diagnosis and treatment should be strengthened. There is lack of data on certain key indicators such as viral suppression rates that could be found out. Encouraging behavior change and decreasing viral load should be our goal. Maximizing the coverage for pregnant mothers receiving treatment at prevention of parent-to-child transmission centers is very important. With already shortage of both first-line and second-line ART scaling up, more is needed. India has achieved only 70% of all 1990 targets. This needs to be enhanced. Additionally, sustaining the lower rates of new infections among vulnerable populations is also important. Sustainable viral suppression among pregnant women should be the motto. Working to attain elimination of pediatric HIV and syphilis should be one of the main agenda. Supply chain management of testing kits should be strengthened. enhancing universal access of second and third line treatment regimen for all should be done. Reducing burnout and enhancing resilience among healthcare providers, especially during the COVID 19 pandemic, is also an important step towards ending the epidemic. Favorable policy environment with a strong political will is needed. In 2014, HIV/AIDS bill was passed by the government. The bill gave a lot of concession to the people living with HIV. They should not be discriminated upon, and a lot of reservations were done to them, but that is not implemented. The HIV bill should be implemented in letter and spirit. If we can do all these aggressively, we can surely bring to zero the infection among general populations, reduce the infection among key populations, end the epidemic for the mother-to-child transmission, and provide quality of life to older people living with HIV, children living with HIV, adolescents living with HIV, and youth living with HIV. This is the right road to ending the epidemic. Thank you.
Hi everyone, my name is Brittany and I'll be talking about HIV in both the US and globally. So the first cases of what would be called AIDS were reported in 1981. Prior to that, they think that HIV traveled from the Democratic Republic of Congo to Haiti in the Caribbean and then on to major cities like New York and San Francisco in the 1970s. There were 5 gay men who were, prior to that, completely healthy, who were diagnosed with a very rare lung infection, a really horrible kind of pneumonia. And this really started a lot of the activism that led to later a better understanding of HIV. By 1983, it was much more apparent that there was something going on affecting key populations, whether that be gay men, black gay men, Haitians, people who use drugs. There was a lot of advocacy in the LGBTQIA community to better understand what was killing everyone, and that really moved the science forward. It was a big influence to why people really started to try to understand what HIV was. By 1983, they had better understood that casual modes of transmission, touching, sharing food, were not true. And in the US, I think there's a pretty good understanding of that. I don't know if that's true globally, but at least in the US, I think that there is a general understanding of how HIV is spread, at least now in 2020. So there are approximately 1.2 million people living in the US with HIV today. 14% of them almost don't know that they need testing. And in 2018, there were 36,400 new HIV infections. Annual infections in the US have been reduced more than 2/3 since the height of the epidemic in the mid-1980s. However, progress has been stalled in the recent years and has leveled at about 38,000 new HIV infections each year. There are key populations that are at higher risk. Gay, bisexual, and other men who have sex with men are the population most affected by HIV. They accounted for 69% of the new HIV diagnoses in 2018. Black and Latinx populations are also at higher risk than their other race counterparts. Obviously, this is not a super clear way to measure. There's a lot of diversity in what it means to be Latinx, so even that is kind of hard to calculate, but these are kind of the numbers that we have. In 2019, there was a new plan by President Trump to work with HIV/AIDS and to push us closer to the 90-90-90 goals set by UNAIDS. This worked to try to diagnose people as early as possible. It worked to treat people effectively and to prevent new HIV transmissions using pre-exposure prophylaxis, PrEP, and other emergency forms of HIV protection like PEP. In New York City in particular, they really utilized this. There was a big public campaign to encourage everyone to know their status, and not only know their status, but to choose either PrEP or PEP. And what this meant is that if people were at high risk populations, they needed to be on PrEP. And if people were not in high-risk populations, they needed to know where or how they could get PEP, which is emergency HIV protection, post-exposure prophylaxis. And this was a good way to try to normalize HIV transmission, to not stigmatize populations, and also to help make sure that everyone was protected. And though this was like a really helpful plan passed in the Trump administration, obviously it will change not only in 2021, but it was, passed kind of late, and also a lot of the other rhetoric shared in the administration has not been supportive of certain populations. Just the push to strip the Affordable Care Act is one specific example of how the Trump administration has targeted, pro-HIV healthcare. The passage of the Affordable Care Act in 2010 provided opportunities for expanding healthcare access, prevention, treatment services for millions of people in the U.S., including people who had or were at risk for HIV. For people living with HIV, there was also new protections in the law that made it easier and more equitable for them to have access to insurance. And that's led to a lot of new coverage, and the stripping of that is really harmful. We also still have a long way to go on stigma. Gay men are still unable to donate blood in the U.S., and that's not rooted in science, but rather rooted in fear of HIV and homophobia. In 2009, President Barack Obama also lifted a 1987 U.S. ban that prevented HIV-positive people from entering the country. The fact that that was still in place almost 20 years later really says a lot about the priorities of our nation. The early years of the epidemic were fraught with human rights abuses and stigma for key populations, including gay men, black gay men, Haitians, hemophiliacs, people who use drugs. And the global HIV epidemic has always been closely linked with negative attitudes towards LGBTQIA people. At the beginning of the HIV epidemic, in many countries, gay men and other men who have sex with men were frequently singled out for abuse by power players in the community. They were seen as responsible for the transmission of HIV, and there was sensationalized reporting about this, leading to a lot of increased homophobia and danger for these populations. We know that criminalization of behavior is one of the major deterrents to overall HIV reduction, not just in the US, but globally. It can deter men who have sex with men from seeking out HIV treatment, testing, prevention, and other services when they need them. Globally, by 1986, almost 90 countries had reported cases of AIDS, how it was known, the fourth stage of HIV. This was a major increase in what they had seen in earlier years. There was a lot of misunderstanding about what this meant, and there was a lot of fear, I think, about what it would mean for the future if we didn't kind of get a better hold on, a better grasp of the science. In 1987, the WHO launched the Global Program on AIDS, and in March of that year, the FDA approved the first antiretroviral drug, AZT, as a treatment for HIV. This definitely led to a lot of other conversations about access and equity. The drug was very expensive, and yet there were countries who had a major increase in HIV infection rates, and they were unable to afford the drug. So the question for a lot of the retailers of this drug was how to keep their profit margins high, as capitalist companies want to do, and then also providing an essential life-saving drug to people who need it. So that was really complicated, and about 10 years later, the WHO declared December 1st as the first World AIDS Day. In the last year or so, there were approximately 38 million people who had HIV/AIDS. There's an estimated 1.7 million individuals who acquired HIV in 2019, which is a decline from earlier years, but obviously not ideal if we're trying to stop the transmission overall. It's complicated too because in some countries, in 2019, almost 80% of people knew their HIV status, which is much closer to the 90-90-90 goals, but not 100%. As you can see on this graph, the darker red areas have higher death rates of HIV/AIDS. A lot of this likely has to do with access to testing, access to treatment, access to other resources that make it easier to live a long, healthy life. If you have access to clean water, to food, to an income that can help you provide ART if your government doesn't provide it to you, if you have access to transportation to help you get to the doctor, these are all things that can make it easier to live a long, healthy life with HIV. And that could be why some of the countries that we see in darker red are having a harder time reducing the death rate. And as a result of large international efforts to respond to HIV, there has been an increased coverage of services. So almost 70% of adults and 53% of children living with HIV are receiving lifelong ART treatment, whether through their government or through a private agency. There are still many gaps in HIV coverage, and this leads us to the 90-90-90 goals. The first one, by 2020, 90% of people who are living with HIV will know their HIV status. In 2018, nearly 4 out of 5 people knew their status, so almost 80%. The second goal is that by 2020, 90% of all people diagnosed with HIV will receive sustained ART, and it's about 80% as well who are able to access treatment among people who know their status. The final goal is that by 2020, 90% of people receiving ART will have viral suppression. 4 out of 5, almost about 85% currently have this. West and Central Africa, Eastern Europe, and Central Asia are still regions where they need urgent action if they're able to meet these goals. We are reaching the last month of 2020, and I think one of the difficulties of reaching the goal by this year has been the COVID-19 epidemic. Lockdown and border closures imposed to stop COVID are impacting the production of ART, the distribution. It's hard for people to get to the doctor. If things keep going like this, there has been estimated 500,000 deaths that could add to this. I think we can't blame everything on COVID. I think that there has been a lack of prioritization on HIV/AIDS in the last couple of years, but I think that what has been done, particularly in the early years of HIV advocacy, that can be used for other illnesses, other epidemics like COVID. And there's a lot of lessons to be learned from the HIV/AIDS epidemic.
Hello, everyone. My name is Madeline Knowles. I'm really grateful for the opportunity to present information today about present challenges of ending the HIV epidemic. I'll be talking a little bit about some of the barriers often faced by people living with HIV and touch on some treatment options and vaccine development progression. I'd like to first start off with a quote. This quote is from someone in the United States. It's certainly relevant, I think, in kind of an international stage as well. It reads, "Ending HIV and AIDS will not only require our government to commit unprecedented levels of spending for research, treatment, prevention, and education. It will also require decision makers to acknowledge that abstinence-only programs waste taxpayer dollars because they don't effectively address HIV prevention. We need a holistic approach that includes race, disability, income, sexuality, gender identity, and other social determinants of health disparities." And this quote is from Stacy Long Simmons. So first, let's kind of talk generally about the challenges to ending the HIV epidemic. We know that poverty plays a large role in not only people's access to health care, but their health outcomes. What the experience of living with HIV might be like for someone living in poverty might be much different than for someone living with much more financial resources and stability. We know that there's still a lot of stigma and misinformation around HIV. And while we hope to continue to work to reduce that stigma via education, I hope I can encourage each of you to perhaps share something you've learned from this video today with someone you know in kind of an effort to reduce that stigma further. We know that discrimination plays a huge role in people's access to healthcare and their health outcomes as well. Lack of healthcare system capacity is certainly now more than ever with COVID and the pressures of the pandemic. We see a lack of healthcare system access and capacity. Finally, a lack of widespread access to antiretroviral therapy and PrEP. So access to, the treatments that we do have available and prevention methods that we do have available, and failing to see those become really, really widespread in the way that we might hope for. So, a little more simply put, some challenges to ending the HIV epidemic. It's estimated that about 20% of people living with HIV in India are unaware of their status. And of course, this leads to potential new infections because those folks are not receiving treatment to reduce their viral load, and they could be unknowingly transmitting HIV to others. We also know that many people might be afraid of testing or unaware of options for testing. So many people, even those who engage in high-risk behavior, might not get tested because they do not believe that they personally are at risk for HIV infection. Others might misunderstand the testing process and not realize that rapid HIV tests can be done, fairly quickly and produce results in as little as 20 minutes. Some people are concerned that other people will find out that they sought testing or that they have tested positive, even though testing is completely confidential. Diverse populations need equitable access to prevention information and tools. So, of course, populations who are most at risk, including female sex workers, men who have sex with men, migrant workers, transgender folks, and other groups have different risks and thus different needs related to their particular approaches and options for prevention. Disparities in HIV rates are continuously fueled by social and economic inequalities, again, like we talked about poverty on the previous slide. And finally, limited resources for HIV prevention. We will kind of come back to this as I talk a little bit about the impact of COVID and how it's influencing our approach to HIV currently. So here's some quick facts on HIV and AIDS in India. I know Louis covered some of these earlier, but I'll just revisit them with you now. We know that about a little over 2 million people are living with HIV in India. So this is kind of what we're looking at. Again, this data is a few years old, but it kind of gives you a snapshot of HIV in India today and what that might look like. So we know what it might look like now. What are the goals? Well, the 90-90-90 targets are a program that envisions these kind of statistical standards, and the goal was for these to be achieved specifically by this year. It's 90% of people living with HIV knowing their HIV status. 90% of people who know their HIV positive status will be accessing treatment, and 90% of people on treatment will achieve suppressed viral loads. So while it doesn't look like India is currently on track to reach this 90-90-90 target by 2020, we're hopeful that it can be achieved within the next few years. So this slide is from the AVAC, and it shows kind of the pipeline for current prevention and treatment options. So in terms of what's currently available, just kind of briefly touch on some of these. We know that we have antiretroviral therapy for people who are currently infected and living with HIV. We have pre-exposure prophylaxis options that are in particular available for people at high risk of transmission. We have barrier methods like male and female condoms that we know reduce sexual transmission, as well as voluntary medical male circumcision, which can reduce female to male sexual transmission by about 60%. And finally, we have a syringe exchange programs. For people who use drugs, needle exchange programs provide a significant opportunity to prevent HIV transmission by reducing the likelihood of blood-to-blood transmission via used syringes. And in terms of what might be on the horizon, what's under regulatory review now is dapiravine, which is a topical HIV prevention method. It's an NNRTI, which can be used intravaginally to prevent sexual transmission of HIV. It was expected that we might hear this year on the regulatory opinion, but that is still forthcoming. Looking even further ahead in terms of what might be or what is under development, we're looking at long-acting injectables, again, preventative vaccines, which we'll talk a little bit more about here shortly, some other options for prevention, including patches, inserts, enemas, or long-acting implants. So let's switch gears specifically to vaccine development. We know there's currently no vaccine for HIV, though to date more than 40 potential vaccines have been tested in the US and over 100 globally. Simply put, the goal of an HIV vaccine would be either to prevent the initial infection, so to prevent that HIV from taking hold and replicating in the body in the first place, or to reduce subsequent viral loads and clinical disease progression following infection. An ideal vaccine would completely block infection opportunities and provide sterilizing immunity. So more broadly, some challenges for the development of a vaccine. Why do we still not have a vaccine? Though we are closer, again, we haven't achieved a successful vaccine yet. Some of the reason that this has been such a challenge is that there are many strains of HIV. We know that there's over more than 60 dominant strains of HIV, which makes it very difficult to develop a universal or comprehensive vaccine. A vaccine, for example, might be developed that is successful for one strain of HIV, but doesn't do a lot to address the epidemic at large. We also know that HIV rapidly mutates in the human body, and that subsets of the virus, which are called provirus, hide essentially in cellular sanctuaries. So this allows the HIV to evade antibodies, which makes it particularly difficult to access or target. There's also no known natural recovery at this time. There's no model for a natural immune response that a vaccine might model or mimic. And a final challenge is that there's no reliable animal models. So in certain other cases, we've used animals to test and explore vaccine options, but we don't have a current animal model that reliably predicts how humans might respond in the case of HIV. Now, looking at approaches to ending the epidemic, these are some points that Louis touched on earlier that I'd like to revisit. One option is to eliminate pediatric HIV in the country. We know that this is possible. We can do this through perhaps universal testing of pregnant mothers or women looking to get pregnant and identifying their HIV status to prevent transmission to their child. We can also reduce new infections among vulnerable populations via prevention education and access to treatment. So, like we talked about earlier, different populations have different needs and thus should receive tailored prevention advice, and a development of the kind of robustness and access of these prevention programs could help to eradicate new infections. We can also work to maintain viral suppression in people living with HIV through consistent adherence and access to antiretroviral therapy. Finally, we can provide better care and quality of life for older people, children, adolescents, and youth living with HIV. We can provide nutritional support, general health and well-being information, ensure adherence to antiretroviral therapies, and do our best to inform people living with HIV on how to prevent progression of HIV in the body. So finally, we'll talk about some additional challenges that COVID-19 and the COVID pandemic introduce to our goals in eradicating HIV. We see restricted access to travel that might be necessary to obtain treatment for HIV or prevention methods for HIV. Of course, we see overburdened medical systems that are struggling to keep up with the influx of patients and healthcare needs due to the pandemic. Funding, research, and healthcare workers may be diverted or reallocated to work on COVID-19. It's in many ways seen as a top priority now, which may require people with expertise in viral transmission and viral pandemics to focus on COVID for a time being. Health product supply chains, including logistics and shipping, might additionally be impacted, which could essentially impact testing options, could impact treatment options, and could impact prevention options in terms of getting those supplies and also getting them distributed. There's also a potential increased risk for stigma due to fear of disease transmission. We know that a lot of people are taking additional precautions right now, which is incredibly important. But our hope is that the precautions do not evolve into a deep-seated stigma or fear around misinformation or negative beliefs about the people who might live with HIV or be at risk for transmission of HIV. So again, my final ask of each of you is, if you can take anything that you've learned from this presentation, share it with a friend, talk about it with a colleague, ask someone you know what they think about HIV. What do they know already about what they can do to help reduce stigma and prevent HIV transmission in their community? Thank you so much.